Welcome you all to our weekly session. How should I treat my patients following evidence-based medicine? This is an endeavor Oncology Club has been practicing for last 1 year plus time, and we have been trying to touch upon all the common cancers, and we have been trying to popularize the concept of evidence-based medicine among our junior colleagues. So by this 1 year time, we have covered breast, lung, and now we are covering the GI session. Today, our topics is non-surgical management of pancreatic and periampullary cancer, radiotherapy, chemotherapy, targeted and palliative care. Our local faculty is Dr. Sazzad Hossain, who is a registrar in Department of Radiation Oncology. So there are many juniors about whom I feel jealous. He is one of them. Not because he is going to be a great oncologist for that, but I am jealous because he has so many achievements in extracurricular activities I wish I have in my life. He was an international level, national level debater, and he has so much accomplishment in his life in extracurricular activities, and he is doing a great job in Cancer Institute. Today, he will be enlightening us on this topic. Our overseas guest faculty is a good friend, Dr. Vineet Talwar, who is the Director of Department of Medical Oncology in Rajiv Gandhi Cancer Institute, Delhi. This is not enough for Dr. Vineet Talwar. He is my last resort. Whenever I am in problem, I send him a text because I know within a minute there will be a response, that the response is always positive. And the response is either he becomes a faculty or he nominates somebody or he manages somebody for me. So he is a problem solver for me. So Dr. Vineet Talwar for joining us as a faculty for today's session. Our president and patron, Professor M.A. Hai, who is also the patron of SFO, is the inspiration for all our activities because this 1 year time, hardly there is any single program where he was not available. He is not always present there. He is actively participating and always providing us support. Thanks, sir, for your continuous support and inspiration. And we are really grateful to Almighty for blessing us with your support. So now I would like to request our president and patron, Professor M.A. Hai, sir, to start the session for me.
Thank you, Dr. Kamal. Bismillahirrahmanirrahim. Assalamu alaikum, everybody. It's my pleasure to welcome you all in this today's session on behalf of our club, Oncology Club, and from the members of the club, and on behalf of express heartiest congratulations. Today's subject is a very important subject, a very difficult problem also. Thanks, and without any delay, we will start immediately. Kamal, over to you, please.
Thank you, sir. So I would like to request to our today's presenter, Dr. A.T.M. Sazzad Hossain, to start your presentation. Over to you, Dr. Sazzad.
Am I audible?
Yes.
My slide is showing the screen?
Yes, it's fine. Please proceed.
Thank you. Thank you, Oncology Club. And before starting, I should give my special thanks and salute to my direct teacher and my mentor, Dr. F.M. Kamaluddin sir, for giving me the opportunity. Today, my topic is non-surgical management of pancreatic and periampullary cancer, radiotherapy, chemotherapy, and palliative management. This is a presentation. Major portion of the patient, 60% patient present with metastatic disease, and resect disease only 15% with borderline resectability. And total overall survival in resected disease patient is more than 2 years, but metastatic disease patients is 5 to 11 months only. If not metastatic, the tumor has to be classified as resectable, borderline, and locally advanced. According to definition of locally NCCN guideline, the locally advanced pancreatic cancer and borderline pancreatic cancer is that if locally advanced pancreatic cancer, the tumor in contact more than 180 degree with the superior mesenteric artery or celiac trunk abutment with superior mesenteric vein or portal vein occlusion with invasion to the vena cava or aorta. But in borderline, it is less than 180 degree contact to the superior mesenteric artery or vein or portal artery. According to ESMO guideline, non-resectable pancreatic ductal adenocarcinoma are borderline resectable and with locally advanced tumors. Borderline resectable or locally advanced, what is the goal of treatment? Palliation versus cure, induction chemotherapy before radiotherapy or chemotherapy or chemoradiotherapy. It is a multidisciplinary decision. Stage of disease and goal of therapy will the decidation point. Borderline resectable patient, stage of disease when borderline resectable, goal of therapy is downstage to resectability. If locally advanced, local goal of therapy is local control or palliation. Resectability is very much uncommon in locally advanced patient. Neoadjuvant meta-analysis in 2020 in their locally advanced patient, locally advanced unresectable patient, if we add neoadjuvant treatment, 33.2% maybe resection may be done, and overall median survival is 20.5 months. But when that is not resectable, that over median survival rate is 10.2 months only. Neoadjuvant meta-analysis in 2012 and 2030. In there, the author's conclusion is that marginal support for resectable disease potentially benefited only for a minority of unresectable pancreatic cancer. But in borderline resectable patient in 2030, in there, they show downstaging is uncommon, benefit may lie in surgical sparing of those with progressive disease. Whatever the tumor is classified as, locally advanced, not resectable, borderline resectable, and technically resectable with expert surgeon, but with important of R1 and R2 resection rates. Surgery upfront is not a good option because of poor oncological outcomes, more than 90 to 95% relapse. Anatomical challenge for radiation because GI structure is close there, and relatively radiation resistance, relatively it is resistance. How to best treatment LAPC if surgery and radiotherapy are not the best upfront treatments? What chemotherapy regimen? For how long? Something else positive afterwards? The AGCO multicenter prospective observational cohort study in their FOLFIRINOX is used as an induction chemotherapy, and that show the stable disease and it show median progressive free survival is 13 months and median overall survival is 22 months. But a US study compare with that with the US study, in their progression-free survival is 16 months and overall survival is 25 months. We will discuss it in later. The meta-analysis of LAPC with FOLFIRINOX, the resection rate is 28% and overall survival is 24.2 months. If disease is controlled by upfront chemo, what can we do? Continue until disease progression and move to second line treatment. Treatment break and chemotherapy holiday, closer radiotherapy or secondary surgery. Role of radiotherapy in the locally advanced pancreatic cancer. Does it important local control or overall survival over or above chemo alone? What is the right time for radiotherapy? Upfront versus consolidation technique, chemoradiotherapy or stereotactic radiotherapy. The two study in there, Cafford et al. And the Lawyer et al. Study, we compare in there upfront concurrent radiotherapy with 5-FU plus cisplatin, and the dose of radiotherapy is 60 Gray 30 fraction, then maintains gemcitabine. Another arm is gemcitabine alone. And this study, upfront concurrent radiotherapy with gemcitabine, and then maintenance gemcitabine in one arm, and another arm in gemcitabine alone. The outcome of Cafford et al. Study is that the concurrent chemoradiotherapy, the median survival is 8.4 months, but gemcitabine alone is 14.3 months. And the Lawyer et al. Study, the outcome of that is that the CRT with gemcitabine is 11 months and gemcitabine alone is 9.2 months. RCT after chemotherapy. Retrospective analysis for 4 prospective trial. RCT seems beneficial in patient control by upfront chemotherapy. In there, the group A, CRT, and all group B is chemotherapy alone. The progressive-free survival in group A is 10.8 months, but chemotherapy alone, the progressive-free survival is 7.4 months. But in overall survival, the group A, CRT, that is 15 months, but CT alone, there is 11.7 months. Preoperative radiotherapy versus immediate surgery for resectable and borderline resectable pancreatic cancer. These studies show that surgery followed radiotherapy, chemotherapy, then radiotherapy, then chemotherapy, followed surgery. In there, the borderline resectability, immediate surgery is 46%, but preoperative radiotherapy, radiochemotherapy is 53%. And RO resection is 28 out of 91 in immediate surgery, but preoperative radiochemotherapy is 45 patients out of 72, that is 63%. Design for Lab 07 study, in there, gemcitabine 2 and 2/4 cycle, then random and another arm is radiotherapy with capecitabine. And it also gemcitabine erlotinib 4 cycle, then gemcitabine erlotinib, another arm, and another arm is radiotherapy plus capecitabine, then erlotinib. The scallop study, in there, gemcitabine, capecitabine 3 cycle, then gemcitabine 1 cycle, and gemox 1 cycle. Arm A, gemox 1 cycle, gemox followed radiotherapy with capecitabine, followed concurrent radiotherapy with capecitabine, and arm B, their radiotherapy with concurrent with gemcitabine. The comparison of these two studies show Lab 07 is there. The chemotherapy overall survival is 16.4 months, but CRT patient is overall survival is 15.2 months. In scallop study, randomized CCRT with capecitabine is overall survival is 15.2 months, and CRT with gemcitabine overall survival is 13.2 months. SBRT for locally advanced pancreatic cancer is there. The show the especially the median overall survival is 17 month. 17 month is Petrilli et al. Study, but scallop and left 07 study is there 17.6 month. Radiation therapy may increase period of rest. This is chemotherapy. This group is chemotherapy, and this group is radiotherapy in there. Is CRT better than the chemotherapy locally advanced pancreatic cancer? Chemotherapy alone, chemotherapy overall survival probability in case in there, the chemotherapy is overall median time of month is 16.5 month. In chemoradiotherapy, the median time month is 15.2. So CRT not superior to chemotherapy alone in Lab 07 trial. Possible option may increase time without treatment in some patients. No superiority of concurrent radiotherapy versus continuing chemotherapy in LAPC patient with tumor control after 4 months of chemotherapy. No standard, but 2 options. 1, CRT well tolerated and better local control with CRT and better treatment-free interval. Encouraging result 15.2 to 16.4 months of survival in patient achieving in similar to phase 2 scallop study. Need how to identify patient who could benefit the most from CRT. Locally advanced pancreatic cancer, what about RCT after FOLFIRINOX? This is this study at the diagnostic time and after surgery. At the diagnostic, survival probability only FOLFIRINOX is 35.5 months, but FOLFIRINOX with CRT is 57.8 months. And after surgery, the FOLFIRINOX for survival probability of FOLFIRINOX is 13.5 months, but FOLFIRINOX with CRT is 47.9 months. This is the USA phase 2 trial, FOLFIRINOX plus RCT, FOLFIRINOX total 8 cycle. If after evaluation of the scanner, no contact with vessel, short radiotherapy. If contact with the vessel, long radiotherapy, concurrent radiotherapy, and the surgery done after 1 to 3 months of short radiotherapy, but long radiotherapy surgery done after 4 to 8 weeks. And these studies show R0 resection possible in 97% patient. Progression-free survival is 40.7 months and overall survival is 37.7 months. This is the algorithm for the treatment for the locally advanced pancreatic cancer, ESMO guideline. If locally advanced pancreatic cancer, performance status above 2, that best supportive care, but less than 2, systemic chemotherapy first with FOLFIRINOX, gemcitabine, nab-paclitaxel, or gemcitabine, or any clinical trials. If disease control, multidisciplinary decision for resection and surgery. If not resected, that continue chemotherapy. To summarize, most of the patients with locally advanced PDSC are metastatic actually. However, a small percentage may reach curative surgery and potential cure. What we know is that we have a start with a systemic chemotherapy. Gemcitabine remains the current standard, but FOLFIRINOX is an option as many papers showed good result. We may discuss radiotherapy after 3 to 6 month chemotherapy in good responses. Only one trial clearly compared chemo versus chemo followed by radiotherapy and showed equivalence. Many ongoing trials will bring now answer in the next 5 years. Now, systemic treatment for metastatic pancreatic cancer. We know gemcitabine is the standard protocol for this, but when FOLFIRINOX trial, FOLFIRINOX and gemcitabine in case of progression-free survival, the hazard ratio is 0.47, and overall survival, the hazard ratio is 0.57%. This is the study design for MPACT. One arm is nab-paclitaxel and another plus gemcitabine. Another arm is gemcitabine alone. Overall survival in there, the hazard ratio of the this is the nab-paclitaxel plus gemcitabine, this arm, and this arm is gemcitabine only. The hazard ratio for death is only 0.72%. In this, in there, FOLFIRINOX plus FOLFIRINOX and nab-paclitaxel plus gemcitabine study is there. This study is gemcitabine and FOLFIRINOX. The probability of overall survival is gemcitabine is 6.8 months, but FOLFIRINOX is 11.1 month. But in this study, gemcitabine plus nab-paclitaxel in this arm and gemcitabine in this arm, in there, the probability of proportion of overall survival is in gemcitabine plus paclitaxel is 8.7 and gemcitabine is 6.6 month. So in there, gemcitabine is 6.6 month, in there 6.8, in there gemcitabine plus nab-paclitaxel is 8.7 and FOLFIRINOX is 11.1. PRODIX 35 study is show in their 3 arms. FOLFIRINOX is 12 cycle, then stop. Arm B, FOLFIRINOX 8 cycle, then followed leucovorin and 5-FU. And third arm is FOLFIRI 3, that is 2 month, and then gemcitabine 2 month. The result of this study that the 6 month PFS is in FOLFIRINOX 47%, in FOLFIRINOX followed leucovorin 5-FU is 44%, in FITGEM is 30%. That means FOLFIRINOX leucovorin followed leucovorin 5-FU, no major difference with only FOLFIRINOX use. Rationale of PARP inhibitor against metastatic pancreatic cancer. Olaparib, a PARP inhibitor, has recommended and demonstrated clinical benefit in germline BRCA mutated ovarian and breast cancer. The POLO, a phase 3 international study, in there arm A patient is olaparib 300 milligram per oral daily and placebo is 300 milligram per oral daily. The result of this study is that in probability of progression-free survival in group is 7.4 month, but placebo group is 0.8 month. Overall survival is overall survival in olaparib is 18.9 month and the placebo group is 80.1 month. NCCN now recommended germline testing for pancreatic cancer in respective of family history. MSI and pancreatic cancer. The MSI pancreatic cancer respond to immunotherapy, but only 0.8% of pancreatic cancer where MSI is high, and the response is only 10%. And this is the milestone trial in pancreatic cancer. In 1997, gemcitabine show better than 5-FU. In 2007, erlotinib plus gemcitabine better than gemcitabine. In 2011, FOLFIRINOX is better than gemcitabine. In 2030, nab-paclitaxel plus gemcitabine show better than gemcitabine. In 2060, lysosomal irinotecan plus 5-FU is better than 5-FU. In 2019, Polo trial, better placebo, olaparib is better than placebo with germline BRCA mutated patient. So any change, major change in there, 2015 and 2020, only maintenance dose olaparib in BRCA1 germ mutated tumor is added. Conclusion, FOLFIRINOX and gemcitabine plus nab-paclitaxel are standard first-line chemotherapy in metastatic pancreatic adenocarcinoma patient. Gemcitabine alone remain the standard of care for a lot of patients. Bed supportive care remain very important in the management of these patients. Olaparib is the first targeted agent which has proven the improvements in response rates and progression-free survival in germline BRCA mutated and metastatic pancreatic adenocarcinoma patient with platinum sensitivity. Thank you.
Thank you, Sazzad. I'm sure it was a huge presentation. I don't know how many sleepless nights you have spent to gather so many information. Now, I would like to request our overseas faculty, Dr. Vineet Talwar, make some comments on the presentation, then we will go to the discussion. Dr. Vineet Talwar.
No, it's quite comprehensive. And in the end, the best part is he has given a good summary. And he has compared what was there in 2015 and 2020. And obviously, we can add in the panel discussion.
So thank you very much. So I'm going to bring up some, real life questions. That is, say after listening to all this data, to you, Dr. Vineet, that you can see that FOLFIRINOX or modified FOLFIRINOX is a wonderful options. We can use nab-paclitaxel and gem carbo, even gem alone. In real life, can you please just give us some tips? How can we select which protocol and which situation? Because FOLFIRINOX is the best one, but we know we cannot use it always. So what is your take? In your real life, how you select all this?
See, everything depends upon the general condition, the performance status of the patient, the comorbidities. So if all these are okay, then probably you go in for the best protocol, that is FOLFIRINOX. Even amongst FOLFIRINOX, we here are using modified FOLFIRINOX. We are not using FOLFIRINOX because that's a very toxic combination. So if the performance status is one notch down, or there is any distressing problem, or the patient has just come out of surgical obstructive jaundice, or the patient has malnutrition symptoms, then probably we might give gem nab-pacli. In other situations, say about 30% times, we can give single agent also. If there are extremes of age, elderly patient, or the patient is not in a good performance status, PS1 to PS2 patients, where you have to individualize everything. So the rhythm would be modified FOLFIRINOX, then gem nab-pacli, then probably a single agent, either gemcitabine alone or probably nab-paclitaxel alone, or just capecitabine.
So one situation always we face that there is a high level of bilirubin. Sometimes we try to bring it down, but sometimes we fail. So patient is there, the bilirubin level is quite high, so 6 or 7. In this situation, shall we wait it come down, or we can try with something else? I mean, either perioperative, metastatic, whatever. But just the question came to my mind, and just want to take your.
So you have to define the intent of therapy. If your intent is palliative, definitely you wait, because you have to palliate this first and then go on to the next one. If your intent is cure, then there are multiple factors which you have to bring into your mind, which already I told you. Comorbidities is a very big factor, and how quickly are you able to achieve a good normal bilirubin level. That also decides when you should start. So if the intent is curative, then probably at about 3 or 4 bilirubin we start off the chemotherapy, and initially we give a single agent. Then probably on day 8 we can add another one as a combination, and keep a close watch on the patient's vital parameters and the labs.
Thank you. So in the ideal world, we always talk about perioperative chemotherapy. Unfortunately, in our real life, we find many patients comes to us after surgery. There is no, in real life, there is hardly any R0 restriction. So we know most of them are R1, sometimes it's R2 restriction. So in that type of situation, I'm sure you also face this type of challenge. So is there anything additional that we need to do if it is a upfront surgery done?
So I guess you have to put your house in order. This decision, whether you have to do a pre-operative chemotherapy that is neoadjuvant, or perioperative or post-operative. At our center, it is a multimodality decision. We do it at our tumor board. So all the cases who have been subjected to curative intent, they are the ones who are brought up in the tumor board. And now the accent is generally towards neoadjuvant chemotherapy. You give the full dose of neoadjuvant chemotherapy, take the best benefit out of it. And then, you do a R0 resection, because R0 resection is the most important in CA pancreas. You've seen that Periampullary study in which you do immediate surgery versus you give some chemotherapy and chemoradiotherapy prior. You find patients who have an R0 resection, they have a median overall survival of about 42 months, vis-a-vis a patient who are subjected to surgery only, they have an overall survival of just 16 months. So now the accent is slowly shifting to neoadjuvant protocols. And then subsequently you see, how to go about and treat these patients. As you also, and as I also know, that most of these patients come in a loco-regionally advanced state. You would be very lucky, 10% cases who come upfront with the small volume disease with the set parameters in which, you can focus and do surgery. So neoadjuvant, either chemo alone or chemo plus RT, reassess, and then of course, give some adjuvant also.
Thank you. In every point, Dr. Vineet Talwar is bringing up one issue that is very important, that we need to really assess the patient and we need to set our goal. Is it a curative intent or a palliative intent? Because in pancreas, this is very important. Shall we chase? If it is a curative, then we should chase. If it is not a curative, we should not chase the patient. And he's always telling that to select the protocol, to take the modality, better to do a multimodality discussion. Unfortunately, in our country, we are not always fortunate like Dr. Vineet Talwar to bring everything under one roof, but still we should try.
So actually, Dr. Kamal, here also it didn't come overnight. With visionaries like you, I think over a period of time, slowly people will start getting into this habit of discussing amongst themselves, and that getting the best out of discussions and going ahead. So this has been an ongoing process and still ongoing,
So are you practicing erlotinib? Say, this type of patient, they are scared and the doctor is also scared. We have done the neoadjuvant or perioperative chemotherapy done, surgery given, even the radiotherapy given. So we're scared of, the recurrence. Any fine morning, the patient may land up with a recurrence. So sometimes we feel like putting something to, in breast cancer, we give hormone therapy. So what is your take about using erlotinib?
I don't think there is any data to support it. Even the study in which you compared gemcitabine with gemcitabine and erlotinib, the difference in the survival was probably marginal. It was in weeks, not even in months, 4 to 6 weeks. So you really cannot define to give a EGFR blocker after the treatment is over as a kind of maintenance. So you're thinking of a maintenance kind of treatment. Well, as of now, it is only the germline mutations in which.
So the message is that even there are some noise sometimes about erlotinib. When this erlotinib came up, there was some noise about use in many sites, including pancreas, but there is no enough data till now to use it as a maintenance. Even some of our colleagues still do it, but it is not supported by any evidence. So the next question I see in the chat box that was also in my list, that should we do BRCA test for all pancreatic patients?
Yes. The guidelines say that you should do for all CA pancreas.
So you share.
Whether they have a family history, whether they don't have a family history, irrespective, all patients should be subjected to a BRCA test if possible.
So the next question, supplementary question is that what is the timing? Do you suggest that when it is diagnosed, we do it, or when we are in need of PARP, that we have exhausted everything, now we're looking for some options and look for the BRCA. If it is positive, we go for PARP. I mean, what is your practice? Do you do upfront or you wait?
We do it upfront because apart from the treatment point of view, it has a prognostic value. Whenever you're adding platinums to the treatment, it has a prognostic value. So we are doing it upfront. Moment we find that the patient is being diagnosed, we do it and then proceed. Probably later on, after you have completed a treatment and you find that it might be useful, we can give it as a maintenance.
So the message is that guideline recommendation also is that to do it upfront. If possible, you should do it upfront. It will give us some prognostic information, and at the later end, it may help us to select a drug like PARP, which have shown some benefit. MSI is a discussion. IO is very interesting drug, but not promising in every places, and the data is not very promising for pancreas. What is your take of IO in pancreas?
IO, if you have that agnostic marker, if you have MSI high, only in that subset of population, as of now, you can give immuno-oncology drugs, because there was one trial, a keynote trial, in which this was given to those patients who were having MSI high, and one patient had a complete response. So you can have surprises sometimes, but only when you have that MSI high, not otherwise.
But Dr. Vineet, like BRCA, again, the question is, shall I do it at the beginning or at the end? I mean, again, when I'm looking for, nothing is there.
Yeah, so the label for immuno-oncology drugs, if MSI is high, you should do it upfront, because you can give immuno-oncology drugs upfront. This is the only indication. So if you have that, then probably, you are, but of course, cost is a factor in India and Bangladesh, both. So that has to be looked. But if possible, if money is no problem, you do MSI, you do TMB, you do DMMR, you do BRCA, you do a host of things, you do NGS also. Find anything useful, you can, use it at a later date.
Yeah, I understand. I agree with you that there is in some patients, we end up in such a situation, we look for some magic. Patient is also chasing, they need some solution. At that time, not only MMR, even we can look for NGS, and maybe we find some target we don't know. Correct. So there is again a question in the chat box from Dr. Mustafa. that how many cycles, 6 or 4 followed by 5-FU maintenance, FOLFIRINOX in metastatic setup. So he is asking in metastatic setup, how many we give FOLFIRINOX, then we go for maintenance. I mean, in metastatic setup, what is your practice?
Maintenance, if the patient is BRCA positive or otherwise.
Okay. So I see Dr. Kudrat Elahi is a very senior medical oncologist of our country. I'm sure he has come across many challenges. So among the discussion, Dr. Kudrat, would you like to add something? Because I'm moving to radiotherapy.
Okay, Dr. Kamal, thank you very much. Nothing special for us, but we have used FOLFIRINOX for 3 to 4 patients, and mostly we use gemcitabine and nab-paclitaxel and single agent gemcitabine. And regarding this BRCA, we have not used any patients for pancreatic cancer. We have no experience till now, till today. Thank you very much.
So thank you, Dr. Kudrat. I mean, these are new things coming up. BRCA, PARPI alike. Once he started this TKI, they tried it everywhere with different experiences. BRCA is also like that, and it is making promise in many places, and hopefully things will change because the newer drugs are also coming in PARPI with different modalities. So, we know that pancreas is not a very promising disease, but we need to look for anything. So now coming to the radiotherapy portion, in your regular practice life, Dr. Vineet Talwar, in locally advanced, when or whom you take the support of radiotherapy, or when you send the patient for radiotherapy, on adjuvant or neoadjuvant, or after observing a very good response or a very selected patient. What is the practice of your center of using radiotherapy in pancreatic cancer?
Give it upfront wherever you have a loco-regionally advanced case. You give chemotherapy 3 or 4 cycles, you find that it is just a stable disease or a slight improvement. You give 3 or 4 cycles more, and still you find that it doesn't come under the purview of surgery. That is the point when we add chemoradiotherapy. Post-surgery adjuvant, if the margins are positive, the standard indications for radiation, that is the time when we add radiation. But generally, we are giving it pre-op as far as chemoradiotherapy is concerned. If the patient is not coming under the purview of surgery, or probably even after chemoradiotherapy, we might again see whether the patient is surgically operable or not.
What is the practice of SBRT in pancreatic cancer? I know it is radiation domain, but I'm sure you also have some experiences in your center. Is it a common practice of practicing SBRT in your center, or no in pancreas?
Not much. We are going across with the conventional radiotherapy.
So I have tried to gather 2-3 slides on radiotherapy. You see, it's radiotherapy in pancreatic cancer. Once it was a big noise, but now it is mostly local control, because we know it is more a systemic disease, and most of the evidence does not show survival benefit of radiotherapy. But we need to make a good selection. SMAD4 gene mutation is something that is in the discussion. Higher technology like carbon, MR-guided radiotherapy, SABR could be some option. So if you look at the data, if you see that radiotherapy have shown some PFS, but not OS. So newer technique is safer, local control, like when you do the gating, so the volume is reduced, you can accelerate the dose, and there is less toxicity. Proton, unfortunately, failed to show any big survival benefit, and carbon and MR-Linac is something interesting. If you look at the SABR compared to conventional, the SBRT volume is less, so we can give a higher biological equivalent dose, and the toxicity chance is less. MR-guided Linac is again a new modality which is showing that we can really focus the disease treatment site, and it is giving a significant survival benefit shown in the published in 2019 Cancer Medicine by Rudras et al. But we need to wait for some more data. Carbon, we know culturally, carbon have 3 to 5 times more penetrating or tumoricidal effect compared to conventional proton. But that's why carbon is very promising in many radios resistant cases. The effort with carbon is going on with pancreas. The Heidelberg, there is a paper that have shown that they have even they have achieved a good control, but another group in Heidelberg failed to show anything. So more paper studies are going on with carbon, and still it is not a total conclusion that it is a big solution. SMAD4 genetic mutation is used to see the prognosis. It is found in around 50% of the pancreatic cancer, and it have shown that this mutation may be a way forward to select who will be benefited from adjuvant therapy. So, I mean, this was few slides that I have tried to gather because we didn't have any specific faculty on radiation. So I tried to gather some information that what is happening around. So we can see neither SBRT nor carbon is showing a definite promise, but there is some hope with Amarlinac. If we can reduce the field size, we can escalate. Maybe there is some benefit. So there is a question from Dr. Mustafa about the role of radiotherapy in adjuvant setup. There is a practice of using radiotherapy in adjuvant setup. There is two types of use. One is neoadjuvant and adjuvant. More promising is neoadjuvant, but yes, if it is R2 resection, there is some role of adjuvant, but again, the role is more local control and still no a big benefit of OS, but we are using it. When you are using it, we are using it with concurrent capecitabine and sometimes with gemcitabine, but capecitabine is more widely used. So, I mean, here I want to stop. So if there is anybody else to ask any question, you are welcome to ask because we have 3 more minutes from our schedule, or we can finish it up. Anybody? Arman.
Hello, thank you. Already, thanks to Dr. Sazzad Bhai for your nice presentation, as well as thanks to the foreign faculty to be here with the Oncology Club in this session. So you have already mentioned my questions regarding neoadjuvant adjuvant setting. One question is there any role of radiotherapy in suboptimally resected pancreatic cancer?
If it is a planned thing, it is no. And as Dr. Vinit Talwar was telling that in surgery, R0 resection is the secret of success. You know, not in pancreas, but I think Dr. Vinit can add with me. There is no site in the whole body where suboptimal surgery can be managed by radiotherapy, chemotherapy, anything. Nothing can replace the suboptimal surgery outcome. It can add something, but it will never be a solution of suboptimal surgery. Dr. Vinit.
Yeah, you're absolutely right. But then, as we had discussed, this is one indication where probably you can add radiation, the margins, and hope that, you know, you can sterilize locally and go ahead with the further chemotherapy in this case.
Thank you, sir.
So in R2 resection, there is a role of, there is an indication of radiotherapy to sterilize and to achieve a local control. But as we discussed, whether it is going to offer us any survival, that is a big question yet to be resolved. So in pancreatic cancer, we can again sum up surgery, R0 resection is the secret with the aid of neoadjuvant or complete total neoadjuvant therapy, mostly chemotherapy, because we have now data that if we can use FOLFIRINOX, there is, it can be enough. I mean, addition of radiotherapy may not be always required in many studies have shown. But again, the question is whether we can use FOLFIRINOX or modified FOLFIRINOX, whether the patient is fit, whether the situation permits, that is the issue. Again, the question is how many cycle, what is the sequencing? Every center have their own practice, their own experiences. And I am sure that with modern time, things will come up. Newer technology of radiotherapy may add. I remember 10 years back, I have seen that SBRT was a promising thing to convert the marginally resectable to resectable. But now FOLFIRINOX has changed the scenario. And again, in metastatic setup, still we are looking for more magic drug to give a more hope to this type of patient, because pancreas is not a very rewarding, neither for the patients nor for the doctors. And PARPI is a ray of maybe chemotherapy combination, and sometime it will shine with some 50%, 60%. In other side, we have seen IO failed, chemotherapy failed, but suddenly some combination have shown some promise. We are waiting for some data like that will show us some promise in pancreas. Finally, I want to congratulate Dr. Sazzad. He has done a great job gathering so many information. I mean, we know when it is a difficult disease, we talk about many evidences because we don't have a good evidence. If we have an easy disease, we talk about 3-4 landmark trial and we solve it. So pancreas is somewhere we don't have a very good data, so we gather many data. Finally, as Dr. Vinit said, he has done a great job by summarizing these things, which will be helpful for our colleagues. And now next week, the same time, we will be talking on management of biliary tract cancer, which will be presented by Dr. Sharif Ahmed, who is an associate consultant in United Hospital. We are inviting you all, and I want to thank our academic partner, Equivida, who has supported us for this program. And I want to thank Dr. Vinit Talwar. Less than 24-hour notice, my good friend responded and helped me, salvaged me like always. He's the salvage therapy for me and for my oncology club. Thanks
always
for
a pleasure. Always a pleasure, Kamal.
So hopefully next week we will be bothering you again, because I know you cover the biliary tract cancer also. And we'll be happy to have you with us. And with these few words, I think we can end up the session. Sir, if you allow, can I close the session, sir? Hi, sir, are you there?
Yes, sure. Thank you all very much. It was a very nice afternoon. We had discussed a very serious discussion on serious disease. For all this troublesome efforts, we cannot particularly get a good result. We still have to hope for spontaneous regression. Thank you all very much.
So thank you, sir. So thank you. Thanks to our local foreign faculties and all participants and our academic partner. See you all on next week, Sunday, same time, to discuss and share our experience on biliary tract cancer. Another challenging thing, and we don't like this type of patient, but we need to see this type of patients. That is the reality. So we'll be discussing this thing, sharing more experiences. Then stay safe and goodbye.
Assalamu alaikum, sir.
Walaikum salam. Bye bye, everybody.